This is my presentation about evaluation and the gaps that I have in how I do it and actually how it's supposed to be done. So it's called the evaluation breakdown. How do I do evaluations? First, I ask them why they came to see us today. So I'll ask them, they'll walk in the door and I'll literally say, why'd you come to see us today? Next step, I ask them their type and level of pain. I ask if anything makes it worse or better, and by it I mean pain. Then I proceed to palpation. You start away from the point of the pain and then you work your way towards it. The fifth step, I do fracture test. I use the squeeze test most of the time. I don't generally do bump. Step 6 is active range of motion. Step 7 is passive range of motion. Sometimes I just do passive overpressure. Actually, that's most of the time, if I'm being honest. Step 8 is a break test. Step 9 is special test. And step 10, check with Nate. And step 11, diagnosis. Why do I do what I do? For step 1, I ask this question to get a history. With high schoolers, I don't generally have to pry with many questions. I say, why'd you come to see us today? And they tell me everything that happened in the last 3 weeks of their life. So generally that's really easy. I don't have to pry with a lot of questioning. Number 2, asking type of pain can help to indicate injury, what kind of injury it is, and then asking the level of pain can sometimes help to assess the level of injury, especially if you know the child or the teenager and you know their level of tolerance to pain. If they come in with high numbers and they are usually pretty tolerant to pain, then you know that's a serious thing. But also it can lead you astray sometimes when kids give you numbers like 8 out of 10 when it should really be like a 3 or a 4. Number 3, which, let's scroll back and look. Oh, sorry. Yep, number 3. Ask if anything makes it worse or better. That can help us to indicate specific set of muscles or specific injuries. So if they say going up the stairs makes it worse, then I can think about things that it could have to do with like dorsiflexion or to pull their foot up, or is it plantar flexion to push their foot down? Is it the bend of the knee? Is it the loading of the femur? You know, all of those different type of things. Number 4, we use palpation to help us assess tissue quality and find areas of specific sensitivity. So we always work away from the side of pain to it, because if you go right for poking out that pain, they're not going to trust you, and it's not going to lead to good results of any of your tests, really. Number 5, we use fracture test to help us see if the injury could be a fracture. We also use this test because if we indicate that it could be a fracture, we don't do range of motion or special test. And so we use this pretty early on to rule out or indicate any fractures that a child might have. Number 6, active range of motion. It helps us to assess if the injury is limiting to the athlete and can help to differentiate between sprains and strains. Not as much with active, more so with passive and resistive, but active range of motion definitely can tell us if the pain is limiting a player in their walking and possibly in the playing, practicing, whatever that they're doing. Passive range of motion is a big indicator of 2 different things. First being anatomical limitation. So if an athlete flexes or dorsiflexes their foot and it doesn't go past 15 degrees, and the other side does, then we can take it through passive range of motion to find out the infeel. So is that bony? Is it hard? Is it soft? To find out if the anatomical is limiting. Or we can also help to differentiate between a sprain and a strain. With a strain, they're not going to have pain with passive range of motion most of the time, but if it's a sprain, they will. I had to think about that for a second, I'm sorry. So that's definitely a great indicator. Number 8, break test is to help us assess the possibility of a muscle sprain. That's supposed to say strain or tear. If we get differences on their strength on both sides, then we can tell that there's definitely an injury. That's definitely probably musculature. Why? Number 9, special tests help us to determine if the injury is ligamentous, muscular, or cartilage. All of the special tests that we do have different implications and different outcomes, and so we use a range of them to help determine our diagnosis. Number 10, checking with Nate helps me not to make a wrong clinical judgment. Since I'm still a student, working and practicing on my own is not something that I can do, and so I'm always going to check with my preceptor to make sure that I didn't miss anything, I didn't overlook anything, nothing like that. And then number 11, giving the patient a diagnosis is the reason that they came to see us, and so sometimes I found that it's hard to not just want to give them a diagnosis of an injury when I believe that they're not actually injured, that there's something just causing them pain, because pain does not always indicate injury. And so a diagnosis allows us to break that down for them. Gaps present in my evaluations. Number 1 is just a big one that I've noticed, especially working in a high school, is any notation of gait or presentation of symptoms when the athlete enters the training room. So the first thing that we should be looking at is, as they enter the door, are they walking with an antalgic gait? How's their posture? How do they move biomechanically? Things like that. And that's something I always forget about. Like, they're practically sitting on the table by the time I get to them most of the time. And so that's something I definitely need to be more aware of. Number 2, history questions, such as, do you hear sounds or feel popping? Sounds are something that unless I think already that it's meniscal or cartilage or labrum in ideology, then I don't usually ask about sounds or popping. That's something that I should definitely implement. I never really ask them about if they've noticed any swelling or bruising. If I don't see it when I evaluate the area, then I just generally discount it, actually. And then asking about previous injuries is either to that area or to adjacent ones are something that I skim over all the time. And that's a piece of evaluation that's pretty important and can uncover some things that you won't know. And lastly, having each patient do their full passive range of motion instead of sometimes just doing passive overpressure. So I tend to get them to do it actively, and then I put them into passive overpressure, where I really feel like I would be able to understand more of what's happening if I took them through a full range of passive. That allows me to just, one, see how their body part moves independently, and then really be able to assess that full range of motion. Implementing all of the things that I have found that I'm missing will come with time and with diligence on my part in making sure that I hit each one of those steps, and then I'm very thorough with my evaluations. Because there's times that I, can be fast and can skip over things, and then that leads to me missing what's actually going on. I can assume it's one thing when actually, had I been diligent and taken my time, I would have seen this is what's actually going on with this athlete. And so I have a diagram written up of a proper evaluation from beginning to end with no step skipped, and so I generally try to picture that in my head and go through it as I go, but I need to do a better job of re-looking over that and really memorizing each step so that I don't miss anything when it comes to my athletes. Thank you for your time.